We are with the IPEG in online meeting, and this is we can do it all of us together. And there is a good foster bonding between the IPEG and the EPSA. And we have the pleasure today that we have the president of the IPEG, Professor Holger Tell. Actually, before we start, we have to say that we missed our friend, Professor Hisham Sakit, that we have one of the first of the Egyptian doctors that have been passed away during COVID-19, because his main interest along the time with us usually was for the education and the training of the MIS. His role cannot be forgotten, and this is with Dr. Eigen. And actually, today, this is the look of my friend, Holger. He is looking at that time to the future, which we are now, and we can see him in a few minutes. And our first presentation today, we have our eminent pediatric pulmonologist in Egypt, Professor Nader Fasih, Professor of Pediatric Pulmonology and Head of Pediatric Pulmonology Unit in Alexandria University, one of the eminent pulmonologists in the region, and he is the pioneer of the interventional bronchology. And he is different because he is unique, making a very good meeting in the Bibliotheca Alexandrina, up to 4,000 people attending. And I will let all of you admire his presentation regarding the congenital lung lesions. It's yours, Professor Nader, now, please.
First of all, I want to thank all my colleagues, Professor Dr. Samah Shahata, Dr. Shri, for this nice introduction about me, but actually I hope to be to the point, and I hope to be tasked to the point, which is today my presentation is about bronchopulmonary malformations. Definitely bronchopulmonary malformations are being detected during the last years with increasing frequency. However, this may be due to an advantage or advances in the prenatal and perinatal imaging techniques. And the bronchopulmonary malformations as a presentations, definitely we have a very wide range of presentation, ranging from just silent and incidental finding due to routine X-ray or CT scan, or it may be severe and life-threatening, which may need urgent surgical intervention. The task already, as we can see here, that bronchopulmonary malformation are often discussed as congenital cystic lesions, which may or may not cystic, definitely. And it includes a variety of different morphologies and definition with different classifications. But nowadays, till now, we have no standardized criteria, definitions, or terminology bridging disciplines which involve it in the diagnosis or care and the prevention of this disease. And actually, fetal ultrasound is altering our understanding of these lesions. For sure that the pathogenesis is due to defective either budding, differentiation, or separation from the primitive foregut. And we have a very huge spectrum of bronchopulmonary malformations. First of all is the foregut abnormalities like bronchogenic cyst, tracheoesophageal fistula, esophageal or neuroenteric cyst, or the airway anomalies like tracheal atresia, bronchial atresia, or tracheal bronchus, or vascular abnormalities like pulmonary sting, alveolar capillary dysplasia, or pulmonary isomerism. The last point is the parenchymal abnormalities, which include pulmonary agenesis or hypoplasia, congenital lobar overinflation, congenital pulmonary airway malformation, and bronchopulmonary sequestration. Bronchopulmonary malformations, now we are discussing about 5 points. The first is the bronchogenic cyst. Secondly is the bronchial atresia. Third issues with congenital pulmonary airway malformations, and then congenital lobar overinflation, and the last point is the bronchopulmonary sequestration. However, this is a review of 306 patients in many centers worldwide, and we can see here that the prevalence of congenital lobar overinflation, congenital pulmonary airway malformation, bronchogenic cyst, and bronchopulmonary sequestrations are more or less equal in prevalence between each others. But actually, the bronchial atresia is much less common as a frequency than the other lesions. And in one of our studies in Egypt, in Alexandria here, we can see here a collection of 166 cases between 2007 and 2015. And we can see here that congenital lobar overinflation and the congenital pulmonary airway malformations are the most prevalent finding in our hospital. And then we get bronchopulmonary sequestrations and bronchogenic cyst are about 50% less than the prevalence of the congenital lobar overinflation and the congenital pulmonary airway malformation. And the least is the bronchial atresia. However, the incident rate ratio was found to be about 1.17. It means that we have a 17% annual increase in the prevalence of these lesions between 2007 and 2015. But taking in consideration that we have a very high birth rate in our country, so we are changing by putting the Poisson module that we can say that we can find that the corrected ratio is 1.15. It means that we have an annual increase by about 15% each year. And also in a review of 52 cases, we can see here that most of the lesions are present in the left upper lobe in about 50% of these cases. And the less common is the left lower lobe. And so both of them considering about more than 75% of the cases. The development of these lesions usually may be attributed to in utero airway obstruction, and based on the level of obstruction, whether proximal or distal. So for example, proximal obstruction like congenital lobar overinflation, or distal like bronchopulmonary, congenital pulmonary airway malformation. Also the severity of obstruction, whether complete like congenital pulmonary airway malformation or bronchogenic cyst, or less severe like congenital lobar overinflation. Also the timing of obstruction, whether early like congenital pulmonary airway malformation or late like congenital lobar overinflation. And we can see here a large group of genes which may be included in this process. And nowadays we can say that how DICER1 is very important and informative about the presence of bronchopulmonary blastoma or not, and its relation to the above finding. So we are starting now with bronchogenic cyst, which we can say that it is the most common cystic lesions of the mediastinum. But it can be present also in any other sites. It can be present intrapulmonary, it can be present intrapleural, or it can be retroperitoneal, it can be present in the neck. It's usually present in the supracarina region or below the supracarina regions or below the carina, and it's usually a thin walled with homogeneous fluid inside. And also we can see here that this patient was diagnosed as right middle lobe pneumonia, but actually we can see that we have a well-defined cystic lesions in the mediastinum, and it was a bronchogenic cyst. And based on the size of the cyst and the presence of its adjustment to either bronchus or trachea, and based on it has compression, whether this compression is partial or complete, we can say a wide range of symptomatology like cough, stridor, wheeze, atelectasis, and in some situations we may get hemoptysis or hyperinflation and respiratory distress. Another patients with bronchogenic cysts, we can hear a thin-walled enhanced mediastinal lesion, fluid enhanced lesions causing marked compression of the trachea. We can see here, this is a bronchoscopic finding of that patient causing severe anteroposterior compression of the trachea, and this patient presented with severe respiratory distress. However, this patient, we can see here that how, we can see this is the border of the heart, and we can hear here a 1-year-old boy presenting with chronic cough and recurrent fever with wheeze, and we can see here tissue, fluid enhanced tissue mass is present in the supracardial region in the mediastinum and pushing the mediastinum towards anteriorly, and how this well-defined fluid enhanced tissue mass with well-defined border, it is a bronchogenic cyst. Then the pulmonary sequestration, in which we have a mass of abnormal non-communicating pulmonary tissue, and this mass we had without normal bronchial communications, and it has a systemic arterial supply, whether this systemic arterial supply from the dorsal aorta or sometimes from abdominal aorta, and in very sometimes we may get arterial supply from the intercostal artery or from the subclavian or any other systemic arterial supply. And this is very important for the surgeon because in very uncommon cases, we may get this abnormal arterial supply, which make a big problem during surgical intervention. The venous drainage is quite variable. We may get it to the pulmonary veins or in some situations to the azygos or hemiazygos. This is an example of the two types of sequestration, where we have intralobar sequestrations, in which within the visceral pleura of the lung, and the extralobar, which less common than the intralobar sequestration, in which have the lung tissue here, he had its own pleural covering. And the intralobar sequestration, which is the most common, is usually not associated with other malformations, but the extralobar sequestrations is usually associated with either diaphragmatic herniation, cardiac malformation, or foregut anomalies. This is another example of extralobar sequestrations, and we can here get the systemic arterial supply from the aorta. Another example of posterior basal lower left-sided sequestration. We can see here the systemic arterial supply from the aorta and how we can get it. Yes, another example. Then we are passing to another topic, which is the congenital pulmonary airway malformation. And however, in our practice, we have a changing definitions and the classifications of these problems. And previously, we can say that congenital cystic adenomatoid malformations with 3 types of classifications. But nowadays, we are reclassifying it nowadays between CCAM to CPAM. So we are changing C to P, congenital pulmonary airway malformation. In the previous classifications, we have just only 3 types of classifications, but the congenital pulmonary airway malformations, now we have 5 types of classifications, 0, 1, 2, 3, and 4. And however, this table, we can say that how type 01, which is very less common or the least common one, which just only in 1 to 30% of cases, in which have many definitions or many classifications, we can say it acinar dysplasia or acinar hypoplasia or aplasia. So all of this due to gross arrest at the pseudoglandular stage, and in which these infants or this newborn usually died within few hours, even with full support, and the lung is usually grossly lung are small. It is also called the congenital pulmonary airway malformation type 0. But the type 1 of congenital pulmonary airway malformation, this is the most common form, and it represents about 60 to 70% of all cases of congenital pulmonary airway malformations. It is usually large cyst, usually greater than 2 centimeters. It may reach up to 10 centimeters or even more, usually present soon after birth and depend on the size of the lesion. However, their presentations usually due to incidentally detection or sometimes complications. It's usually single predominant one, or sometimes we have associated multiple small cysts. It's usually affecting one lobe in 95% of cases, and it may be unilateral in most of the cases, but sometimes we get multifocal with affection of both lung fields, and this is extremely uncommon, or bilateral. This is another CT of other patients with fluid containing congenital pulmonary airway malformation. Another patients with all these of our patients in our practice in Alexandria University. And this is another patients with small thin wall cystic lesions in the left lung. We can see this is the CT of the patients that how we can huge thin walled cystic lesions. However, we may get septation like that. Another patient of complicated CPAM type 1. However, the risk of association with bronchoalveolar carcinoma is extremely uncommon, especially in type 1. It usually presents in older patients even after surgical resection of the patients. However, type 2 is less common. It represents about 15 to 20% of the cases. The cysts are usually small and about 2 centimeters. And second most common form, it is usually single lobe affection. And type 2 is usually commonly associated with renal anomalies, congenital diaphragmatic herniation, congenital heart regions, and sequestration. However, in case of sequestration, the lesion here, we can a systemic arterial supply, and this lesion is termed now a hybrid lesion because it has a hybrid lesions. This is an example of CPAM type 4 with systemic arterial supply, and what we can say here, hybrid lesions. However, type 3 is entire lobe affection. It represents its incidence between 5 to 10% of the cases. It sometimes causes mediastinal shift with compression of the hypoplastic adjusted lung, and usually this lesion is non-cystic lesions. However, usually we have severe respiratory manifestations and may survive if hypoplasia is not so severe. The problem with type 4 lesions, which is presenting about 5 to 10% of the cases, usually that its presentation is exactly similar to type 1 CPAM. But the main problem is that it is much less prevalent, and the similarities of between CPAM type 4 and the prevalence of bronchopulmonary blastoma. However, the link between CPAM type 4 and the pleuropulmonary blastoma is very interlinked with each others. And we have classifications of bronchopulmonary blastoma is type 1, in which we have a purely cystic lesions, type 2, in which we have partially solid, partially cystic lesions, and type 3, which is purely solid. This is an example of one of our patients with pleuropulmonary blastoma, in which we have partially solid and partially cystic lesion, and this is example like type 2. However, this is a very deceiving CT finding, in which many of the pediatricians or pediatric pulmonologists and sometimes surgeons may go past through without being that this is a pleuropulmonary blastoma. This is another example of cystic lesions. This is purely cystic one. And then we passing to the bronchial atresia, in which in the past it was known as it is not yet well less common, but actually nowadays we should know that it is one of the presenting very commonly, and now become one of the commonest or even the most common presenting congenital pulmonary airway malformations. This is the gross picture of the bronchial atresia, and we can see here that an enhancing lesions in the epicoposterior bronchus causing complete obstruction, which is exactly similar to inspissated mucus together with hypoattenuation or low density of the epicoposterior segment of the left upper lobe a picture which is highly suggestive of bronchial atresia. This is definitely another patient is congenital lobar overinflation, in which we have a mediastinal shift that causes shift of the mediastinum to the other side, together with also ipsilateral compressive or compressive symptoms causing marked compression and collapse of the same side. The systemic arterial connection, which is one of the very important, it may be isolated or it may be associated with bronchial atresia, here what we can say intralobar sequestration, or with CPAM, as we can say what we say hybrid lesions, or with extralobar sequestrations, which is atypical features. However, the surgical management or the management of bronchopulmonary malformation, will be left to our Professor Gelter, who will present the surgical management, but we should know that we have a debate about if we have moderate to severe symptomatology, I think that surgical intervention here is mandatory, but if we have asymptomatic patients, here we have controversies. Even we are doing surgical intervention or to pass through conservative therapy, and in both we have two opinions, both of them to be considered, and I think that this will be lost for the other to the next presentations. And my recommendations in this presentation is to definitely, we are in need to define the anatomy and clearly state nature of the airway, arteries, veins, and parenchyma before giving the lesion its name. And primary importance of gross examinations, and also we should resist the impulse to name everything, because we cannot sometimes doing the name for everything. Then the appearance of the lesion changes over time. Definitely this change will differ between fetus, infant, older children, and adults. And so all of us, we should know that, even taking the possibility of the complications. And also we should remember that the age makes the difference. And thank you. And I'm sorry for interruption.
Thank you very much, Professor Nader. As for me, I can stay listening to you and studying for 1 hour, but because we have a lot of audience, and now it is time for Professor Holger Tell. Professor Holger is a professor on the head of Department of Pediatric and Adolescent Surgery in Graz University, Austria, and he is one of our best friends and the current IPEG president. Welcome on board for the surgical management of congenital pulmonary malformations. Please come in.
Dear friends from Egypt, first of all, Professor Sami Shehata, Professor Sherif Shehata, thanks for this very, very kind invitation. I wish I could be with you in Egypt, but we all know that this pandemic is asking us for different strategies. Can you hear me well? Okay.
Yes.
And I hope the video works. I changed rooms because everybody in Austria is now on the internet. After this fantastic presentation from Professor Fissure, I will not go into the talks about the indications and everything. Everything has been said so well that I will go right down to surgery. I will take about 5 or 8 minutes for the basics and then talk to you about two techniques. One is a rather simple so-called extralobar BPS, and then a lobectomy. But every time I give this talk about surgery for pulmonary malformations, I think it is extremely important, especially for the younger ones, to stress once again that all of these lesions are so unique with their vascular supply. As Professor Fissure said, each lobe is different, that the younger ones need to train understanding the lung. On the first sight, nobody really knows who is feeding whom and where is feeding what. Secondly, for the younger ones again, we have 5 lobes in the body, and each lobe is different. You must study those. We all know that as surgeons that the lower lobes, the left and the right ones, are the easier ones. But when it comes to the upper lobe, it's called the so-called D lobe. D stands for delicate or even death, because the A2 artery arises on the posterior side of the fissure. It's not on the frontier side of the fissure, and somebody who is not trained well doesn't understand that. And again, the middle lobe is the mastery level. And I'll come back to that. Patient selection. We've heard the pathologies. I won't do that again. It's already been done very well. When it comes to surgical patient selections, please just remember, newborn surgery is mastery level. This is the typical picture of a 2-day-old, 2-kilo body weight infant with obviously a left lower lobes, CPM with cardiopulmonary instability. Now, this is not a beginner's case. This is probably not even the case for thoracoscopic surgery, except for maybe Steve Rothenberg and these superheroes who can really do this. But other than that, it's mastery level, open surgery, careful surgery. The same thing applies to emergency surgery immediately after newborn on the mastery level. In my setting in Europe, we probably try to postpone surgery until the age of 6 months, maybe even 12 months. The only thing I appreciate is we've done recently a study about the so-called hidden, silent chronic infection. We're looking at the pulmonary, lower pulmonary microbiome, airway microbiome, and it seems that there is more chronic inflammation than we think, but that's up to the next generation to discuss. Final thing about patient selection, the big cysts are the good cysts for the surgeon. You simply decompress and you've got all the room. Very briefly, port placement for thoracoscopic surgery. Most of us stand in front of the patient. This is the tip of the scapula. So this is a 5-3-3. This is a 5-5-3 approach. You need probably in your right hand a 5-millimeter instrument for all the energy devices you want to do. And then remember that the scope is usually above the fissure in the mid-axillary line. And then depending on the lobe, you swing either upwards or downwards, whether you do an upper lobe or a lower lobe. This picture is thrilling most of us. Again, this is the same 2-day newborn with 2-kilo body weight, which I did openly in this cardiopulmonary crisis. And what's really challenging now is in these fine structures that you have a almost fused fissure. Fissures may be complete, partially incomplete, or totally incomplete. Whether you do it openly or thoracoscopically, doesn't matter. You've got hook cautery to delicately sweep the pleura away and nicely dissect down to the structures you want to do. The ligature is fine. And in older children, only in older children, clamps or staplers are advised for the division of the fissure. I'll show you 3 brief videos. These are for the younger ones, just for the technical aspects of doing it. Here's the hook for the fissure. These are 60 seconds videos only to get you started with the surgery. And you appreciate how nicely you can use the hook to divide the parenchyma without damaging anything else. Especially in incomplete fissures, this is helpful. Once you know what you do, sweeping motions, and once you know what you do, so you aim down here to the pulmonary vein, and this is obviously an upper lobe being done, you can nicely isolate everything you want to see. So that's the first video about fissure and parenchymal division. Vascular control, extremely important. Especially when you do thoracoscopic surgery. You have 30 seconds, if you damage the vessel, 30 seconds to save the life of the child. So better be slow, better be careful before. This is one of the key teaching. Create enough length. You can then ligate with either all of the different vessel sealing instruments. You have ligature, just right, clips, hemolocks, or in only the larger childs, but then it is very clever and helpful and fast. Once you have a stapler in there, use it for the bronchus and the vascular. Okay, short video again, very short video. This is obviously an intralobar sequestration. The vessel is coming through the diaphragm into the left lower lobe. Nice big vessels, scissor that doesn't cut. And here's Steve Rothenberg. He's doing a middle lobe, lower lobe, upper lobe, middle lobe, and just uses the just right 3mm instruments. This is a larger child. This is the bronchus. This is obviously the pulmonary arteries. And I enjoy this hook technique where I simply lasso the vessels, then lift them up and then have major control. Big child, 12mm stapler for the bronchus and for the vessels, white magazine, white for vessel control. And then of course, bronchial closure depends again on the size of the patient. I think the easiest is the 5mm or the 3mm clip. This is Steve Rothenberg again, in a very small child in an upper lobe. This is the artigus vein, upper lobe. And this is the same child you saw before from me, where we did the vein with the stapler. And here comes the stapler again for the bronchus. This is the vein, this is the bronchus. And you sleep very well in these older children. Okay, so these are the technical skills you need, whether you do it open or you do it thoracoscopically. These are the technical skills you need to have on board to go. And like I said, I'll just do 2 entities. These are the starter ones, the simple ones, the so-called simple ones. This is a really beautiful left extrapulmonary sequestration. This is the diaphragm. This is the left thoracoscopy. Once you move this little mushroom or whatever you think, you see just the pedicle of it, of vessels cruising through the diaphragm into the sequestration. Be aware that these are hyperplastic vessels, but other than that, it is technically just a beauty. It's a beginner's case. It is just fascinating, and everybody will be happy as long as you follow the surgical rules, how to do it right. But like Professor Fissure said, it's a fascinating topic when it comes to sequestrations like these. This is obviously a mediastinal sequestration. The blood supply is unclear despite all fine imaging. This is the aorta, this is the inferior vena cava. This is obviously something going into there from the vena cava. And here you see some arterial branches. Once you do those, nice, right. Let's see that one. We approach this one, the mediastinal mass, from the right side. So this is the inferior vena cava. This is the lesion somewhere in here. This is the diaphragm. This is the left lower lobe. Pulmonary ligament already mobilized. You see the phrenic nerve riding down here through the diaphragm. For a while you think, well, is that the way to go? This is the esophagus. This is already the pleura of the right side. But if you get the techniques on board, stay with the lesion. And you slowly will develop an inferior vena cava, esophagus, already pleura of the left side, approaching from the right side, and you slowly develop it. I hope the video is showing. Sami, video okay? Yeah, and then you ask yourself, well, where are those vessels? And here they come. This is probably the venous branch. Nice vessel here. Actually, we had 2 of them, to our surprise. And then you finally find the arteries. The benefit for the child is obvious. How would you approach such a lesion openly? Well, yes, you could do left-sided thoracotomy, but that's deep down in there in the diaphragm. Yes, you could do a mediastinum and a sternotomy, but that's a huge intervention, huge access to this lesion. And I guess it proves the point for a thoracoscopic approach. Okay. So my summary for the extralobar sequestrations is these are beginner's cases as long as you know the anatomy and the vascular supply well. It's usually an easy shot. Some of them are dangerous, but again, preoperative imaging will take care of those. And finally, I'll go to the intralobar malformations. Again, I would like to stress my love for anatomy. How many arteries has the right lower lobe? I'll ask that question later. But obviously, the right lower lobe has the basal trunk and the superior segment A6. How many arteries has the left lower lobe? Only one. So already the lower lobes between the right side and the left side are different. And I advise really everybody who has not been trained extensively in thoracoscopic surgery and thoracic surgery to go down to one of these beautiful atlases and prepare every case before you do. So you have the A6 artery dangerously coming from behind. You have only one main bronchus together with the A6, the B6, and then you have inferior pulmonary veins. And the thrills for that surgery, which is a simple surgery, it's a simple slope, is that the middle arteries for the A and 4 and 5 on the right side arise exactly from the basal trunk. So they would come from here instead of here. Okay? And these variations must be known. Good. Other than that, easy lobe. Let's do it. And then we summarize everything we had. You take the hook for the sweeping motion to get the fissure. This is an almost complete fissure, beautiful fissure. Part of the parenchymal dissection, you just take the ligature. It is a beautiful instrument to dissect and then seal. And obviously here you already see the pulmonary arteries coming. Again, we expect two arteries, basal trunk, and then the A6. You take your time, you try to get enough length. Behind the arteries is always the bronchus when you approach it from the ventral side. And if you're not clear, you simply dissect into the parenchyma. You lasso it like I enjoy doing it. With this lasso, you lift it up, get enough length, get it off the bronchus, and then clip it down. Like Rothenberg told us, only cut half of it to make sure that the seals are tight, and then you cut the rest. Second artery, A6, the posterior one, the lasso, gain enough length, clip it well. Then you go for the pulmonary vein. That's the window between the pulmonary vein and the bronchus. You tie that one down, clip it down like you saw before, and all that's left then, clip, 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 is the bronchus. If you're not sure where the B6 bronchus is, again, two bronchus, main trunk and B6, then you move your way into the parenchyma. Forget about these little tiny air leaks. They don't bother you much. And once you make sure that on the right side, you're not damaging the middle lobe bronchus, right side, middle lobe bronchus, then you just do what you used to do and tie it down. Okay, I think with that,
Dear Professor Horger, you have 3 more minutes.
yeah, and I only need 2.
Okay.
what does the literature say? Well, obviously, tissue trauma for thoracoscopic surgery is better than open, less tissue trauma. That's a nice study from a good friend, Ki Long Wong in Hong Kong, with a nice group, which basically just so that the long-term pulmonary function test after lobectomy is better than open. That's probably due to impaired muscular and fused fissures, fused ribs, sorry. And Steve Rothenberg proved very, very early that even in small infants, such surgery must be done and can be done as long as you understand the pathology, like Professor Fissure said clearly, and you know the surgical rules. So in conclusion, dear friends, thoracoscopic surgery or thoracic surgery for these pulmonary lung formations is a really fascinating area because of the high variability of pathologies and pulmonary anatomy. If you know your skills way, patients will benefit. And I think it is a nice area, a special area for us as pediatric surgeons together joining in the decision-making with our colleagues from pediatrics. So I'm done, but one word, I miss you personally. Wish I could be with you. Super thanks. Okay. Finish, finito.
Okay. Thank you very much, Professor Holger, for your nice presentation as Professor Fissure. And so we can stand for hours following, but this is the first poll we participant to take in.
Yeah, for the poll, never use the ligature.
Safety comes first. And actually now we will have Dr. Ahmed Faris. Dr. Ahmed Faris is a professor of pediatric surgery and the chief of department in Fayoum University, Egypt. And he has a great experience and training from Cairo University. He will present the Egyptian experience in 15 minutes. Please, Dr. Ahmed.
Today I'm going to talk about our experience in Cairo University, the hospital where I was trained for the management of congenital lung lesions. I will not go through the classification as Dr. Nader have already mentioned most of them, but I will show just a few slides. The name was changed, as we all know, from CCAM to CPAM, with adding of two types, type 4 and type 0, which is actually a rare types. The most fearful complication from CCAM that can present after birth is the fear of infection in 25% of cases, and fear of malignancy, which incidence between 1 to 2%. That is the pleuropulmonary blastoma. Also, this is the picture of pulmonary sequestration. This is the CT scan of patient with bronchogenic cyst, which could be either in the mediastinum or in the lung parenchyma. Regarding our experience in Cairo University Children's Hospital, we have been managing congenital lung lesions since long time ago, but the cases that we were facing is CPAM, congenital lobar emphysema or overinflation, mediastinal cyst. As we are in the developing country, we have few antenatally diagnosed cases. This will affect our management. So we don't usually face non-symptomatic cases because screening by antenatal ultrasound is not widely done for during pregnancy. So that will affect the outcome of or the management of our cases. Usually all of the cases that we face present with the respiratory symptoms, and the age of presentation is usually older. Not all of the patients are present in the neonatal age, especially that the patients that were asymptomatic. Also, the presence of repeated chest infections in our patients had caused adhesions between the fissure and between the chest wall, which makes the surgery more difficult. We started doing thoracoscopic management of congenital lung lesion in Cairo University in the past 3 years ago. This our experience with the management of thoracic surgery, especially in the repair of congenital diaphragmatic hernias and esophageal atresia and tracheoesophageal fistula. Also, our anesthetist team are becoming more comfortable with the thoracoscopic surgery and management of CO2 insufflation in the lung. All these factors have encouraged us to start thoracoscopic treatment of congenital lung lesions. Before the era of thoracoscopy, we performed about 25 cases from 2011 to 2018. But recently we had 5 lobectomies. 3 of them were completed thoracoscopically. One started open surgery because the neonate was distressed, and the other converted to open due to extensive adhesion between the lung loops and the parietal pleura. We have excision, thoracoscopic excision of 6 mediastinal masses, 2 cystic hygromas. These hygromas were extending from the neck to the chest wall. So the thoracic component was done thoracoscopically, and 4 bronchogenic cysts. In the early cases, we did it open, but the last 2 cases was done completely by thoracoscopic approach. When we go to the, as Professor Horgel said, to the anatomy of the bronchus, because we have to study these pictures where the artery comes, and if the artery is in front or behind the bronchus. This is very important to revise, especially we are concerned with this revision before each operation. If we are going to deal with a lower lobectomy of the right or the left side, we study the group that will do the surgery, will study this anatomy and revise it importantly and correlate it with the CT finding of the patient to improve the safety during surgery. Trocar site is positioned according to whether it is upper loop or left loop. I will show you a small hint about the cases that we have mentioned. The first case we done was a 7-month-old male. We did for him, this is the CT scan of him, has right upper loop CPAM. We did right upper lobectomy. The patient stayed in the ICU for 2 days and discharged on the 5th postoperative days with no complications. The second case presented at day 12. He was a full term with no associated anomalies. He had a right upper loop CPAM. He was on oxygen, nasal oxygen, but we decided to wait since the baby was stable. On day 20, the patient deteriorates and the cyst suddenly enlarged in size, as we can see in this X-ray. He becomes ventilated, but we managed to do a thoracoscopic right upper lobectomy. Third case was diagnosed antenatally by ultrasound. The patient was asymptomatic at birth. However, a mild attack of tachypnea occurred and this does not necessitate hospital admission. He was discharged on day 2 and operated on the 3rd month. This is the CT scan. He has left upper CPAM. We did the surgery at the age of 3 months. It was left thoracoscopic lobectomy and it was successful, and the patient did well after surgery. I will show here the video done by Dr. Mohammed Al-Barbari. We used the LigaSure instrument. I hope it will be clear, to divide the veins and arteries of the left upper loop. Then the bronchus was dissected carefully. We used Hemolox. This is we enlarged the incision because this is a 10 millimeter Hemolock. Then complete isolation of the left upper loop, and it was excised. The patient have a very smooth postoperative course. The fourth case was antenatally diagnosed male boy. He presented with respiratory distress at birth, no associated anomalies. One of the problems that we faced, the patient was distressed, so we decided to do open surgery. As you can see from this CT scan, this baby has a lesion in the left upper lobe and also extended into the lower lobe. When we do the surgery, the cystic lesion was involving mainly the upper lobe and small part of the lower lobe. With complete obliteration of the fissure, we couldn't demarcate between the upper and the left lower at the start of the surgery. Excision was done for the upper lobe, and almost the superior segment of the lower lobe was removed. We confirmed that the lower half or the lower 1/3 of the lower lobe was ventilated nicely at the end of the operation, and the patient has good outcome. Although as we removed a large part of the lung, he remained with like a pneumothorax or something like this for a long time, but he went okay. This is a brief account of our cases. We hope that we in the future we are expanding our work in thoracoscopic surgeries for congenital lung malformation. Thank you.
Thank you, Dr. Ahmed, for your nice illustration of the short experience from Cairo University. And now it's time we are inviting Dr. Aydin Yagmorlu. Professor Aydin is Professor of Pediatric Surgery in Ankara University. He is one of our best friends. He is the President-elect of the IPEG Middle East. And I have the honor to be his Vice President at the current. And in the audience is Dr. Inam Ruboui, also the current president of the IPEG Middle East chapter. And he will give the talk regarding safety and complications of thoracoscopic intervention in thoracic surgery. Tashakkurey, Dr. Aydin.
Thank you, Sherif. It's a great pleasure to be here and to be invited here. First of all, I want to thank the Egyptian Pediatric Surgical Association and the organizer for this panel. And all of the speakers outlined very important issues on congenital lung malformations. And now it's my turn to talk about the unpleasant side of these delicate and advanced surgical procedures. I mean, the complications. And I'm going to talk about the safety issues in order to prevent these complications, which Holger stated very clearly that we have to be very careful. We have to know the anatomy very well, and we have to be stick to the principles in order to prevent these complications. I have nothing to disclose. What I can say that the traditional surgical approach to congenital lung malformations has been the open thoracotomy through the posterolateral way. And open thoracic surgery at early age was found to be linked with later chest wall asymmetries, poor cosmetic results, and also scoliosis. In 2003, Stephen Rothenberg was the first to report the thoracoscopic lung resection in children. As far as I remember, his group included around 50 patients. And the age range was between the neonates and up to the 18 years of age. And the smallest baby was around 3 kilograms. And since then, the thoracoscopic approach has been described as technically challenging. It's an advanced operation, but with reduced and short and long-term morbidity compared to the open surgery. In large patient collectives, thoracoscopic lobectomy has proven to be a safe procedure, especially in adult surgery. In the surgery of adults, however, a learning curve of the respective surgeon is clearly described. The same applies to the performance of thoracoscopic resections in also childhood. The problem is the fact that these procedures are carried out very often in thoracic surgery departments in adult surgery, and therefore a corresponding experience can be gained quickly. In pure departments for pediatric surgery, however, the operating frequency is often not large enough to establish this method. So you have to gain much experience to do more cases, but these cases are really very limited. So this means that experienced thoracic surgeons operate the children at institutions where, in addition to departments for childhood surgery, children's intensive care facilities are available. And against this background, the question arises whether the thoracoscopic lobectomy or thoracoscopic lung resections lead to measurable advantages in pediatric patients. In the review of the literature, a lower complication rate is found for the minimally invasive procedure than in the open surgery. And the average surgery time, of course, is much longer in the case of thoracoscopic procedures, but it's getting closer to the open surgery. And while the length of stay in the hospital stay is shorter in thoracoscopic surgery cases. To minimize complications, we have to be aware of some technical difficulties. I mean, the technical difficulties in thoracoscopic operations in children concern surgical aspects and also involve aspects pertaining to the anesthesia procedure, which result mainly from the small anatomic size of the pediatric patients. And the main message is there are many anatomic variations. As Holger stated, the anatomy is very important, but there is also very much variations of the anatomy in terms of the arterial supply. And so always a broad dissection, a nice dissection is mandatory to perform a correct thoracoscopic pulmonary resection. And the first step is always controlling the arteries first, and subsequently the pulmonary veins, and then the bronchus. Holger and also Ahmed described the technical aspects of this advanced surgery in detail, so I'm not getting into it once again, but in order to minimize the complications, we have to emphasize some important steps. Thoracoscopic resection of congenital lung malformations can incur both intraoperative and postoperative complications. However, multiple case series have demonstrated a low incidence of overall morbidity and no difference in complication rates between minimal invasive and open approaches to resection. In the meta-analysis, I think Nasr and his friends made it, found a 21% rate of overall morbidity and 16% rate of respiratory complications. Most commonly, this most postoperative complications is pneumonia. And the most frequently described intraoperative complication includes hemorrhage requiring transfusion, bronchial injury requiring repair, phrenic nerve injury, and incomplete resection of the lesion. And common postoperative complications include the pneumonia and persistent leak or pneumothorax and need for blood transfusion. We have to state that additionally, while not a true complication, the most common anticipated intraoperative event is conversion to an open procedure. Various centers report different rates of conversion. It's ranging from 1% to 50%. And one established risk factor for conversion is the presence of preoperative infectious symptoms. And conversion rates are really lower in asymptomatic patients. So there became the question is, do we have to treat the asymptomatic patients? Do we have to operate them or not? It is an ongoing debate, so we can discuss this later. And other factors that may increase the risk for conversion are procedures done early in the surgeon learning curve and patients less than 5 months or 6 months old. But there is a controversy regarding this subject. It's an ongoing debate. And in some reports, though multiple series have demonstrated high rates of thoracoscopic success in the procedures done early in the surgeon learning curve, which I don't agree, and the patient age less than 6 months or neonates. But in experience sense, the success rate is really high. In general, the surgeon should consider conversion to an open procedure when he or she is unable to safely visualize, dissect, delineate, or divide the hilar structures. And specific barriers to safe hilar dissection include the pleural adhesions, aberrant hilar anatomy, and incomplete fissure and hemorrhage. Sources of bleeding during thoracoscopic dissection include the intercostal vascular injury, inflammatory pleural adhesions, and injury to the hilar vessels. While not immediately life-threatening, bleeding from inflammatory adhesions can result in acute blood loss, and it may require blood transfusion and can prevent the visualization of the hilar structures, resulting in conversion to an open procedure. Since there could be a huge variation of the anatomy, a broad dissection is essential. Following basic surgical principles, hilar vessels should be identified and controlled circumferentially prior to attempts at division. So the blind division with a vessel sealing device is not recommended. To avoid possible risk, the most safe method to control the arteries is to ligate them, as Holger demonstrated. Although it can lengthen the operative time, it's much safer and you can go and have a nice, good sleep at home, back home. And you can use vessel sealing devices, but they may sometimes get sticky and tear the artery during the removal. And as most of you know, there are more delicate and smaller size 3 mm instruments for this purpose. And we can use titanium or plastic hemolux in order to prevent, to ligate the arteries or the vein. They are not safe as much as the ligature, but you can use them. And never ever try to use a bipolar or monopolar hook cautery to control the arteries. It's very important. An incidental injury to these vessels incurred during dissection or division can produce life-threatening hemorrhage. Methods for controlling a vascular injury include the local pressure, which I think it's not very useful. You can make a suture repair, but if it's a huge bleeding, you have to convert it to open. You can ligate it. If you can be able to do it, you can do this. And these injuries often require emergency conversion to the thoracotomy. And there must be always a thoracotomy set, including the vessel clamps in handy. And also there must be available blood at the operating theater for immediate transfusion. And again, I want to recommend that do not hesitate to convert the thoracotomy in case of any suspicion. Though rare, the thermal injury, staple injury, or laceration to an adjacent or incorrectly identified bronchus or bronchial can lead to major morbidity, including complementary lobectomy. If you identified it intraoperatively, you can successfully primarily suture the repair and put some pleural flaps, turn some pleural flaps in order to prevent the air leak. Or if you cannot do it, do not hesitate to convert to open procedure again. And of course, you can miss the injury. You cannot see the injury. And the missed injury result in a prolonged air leak and often sometimes necessitate reoperation for bronchial or bronchiolar repairs. One other problem is the risk of incomplete resection. And it depends on the surgical approach. I've seen that there were several questions regarding do recommend segmentectomy or not. We can call them non-anatomic resections. These non-anatomic resections demonstrating approximately a 15% of risk of incomplete resection. But if you compare it to the formal lobectomy, the risk of incomplete resection is almost zero. So this may be due to observed low sensitivity of contrast-enhanced CT scan for identifying secondary lesions in the affected lobe. And in cases of residual disease identified on postoperative pathology, reoperation should be considered to gain clear margins, or to perform formal lobectomy. You can go and make a formal lobectomy. And if residual disease is missed, recurrent infections and the possibility of malignant transformation must be always keep in mind. In most case series reports, rates of persistent air leak and pneumothorax less than 10%. It's not so much. Air leaks can originate at the bronchial staple or suture line, a transected bronchial, or a missed injury to an adjacent bronchus. And small air leaks will often resolve with continued thoracostomy drainage. However, if the lung fails to fully expand, or the air leak does not resolve, reoperation may be necessary to identify the address bronchial or bronchiolar injuries. And approximately 5 to 10% of patients develop postoperative pneumonia following thoracoscopic lung resections. The initial treatment is, of course, with intravenous antibiotics, and while obtaining imaging to assess for undrained pleural effusions that may become infected. And any undrained collections that is observed during a CT scan should be drained separately. And if there is a development of purulent drainage, it may require reoperation with a chest washout. To summarize, these are my principles to avoid the complications. I'm always using the blunt trocars to avoid a parenchymal injury in the beginning of the operation. And I always warn the anesthesiology when I'm entering the thorax in the beginning of an operation. If a parenchymal hemorrhage can occur, it will totally mess up the whole surgical procedure. And if there are huge cysts, you have to deflate the huge cyst first and then create space. You have to be very obsessive about the safe control of the vessels. So you have to circumferentially dissect it, isolate it, and enough length, and then ligate it. You have to be very careful about using energy devices. Do not trust them. They cannot sometimes make a proper way. And never use a stapler without dissecting clearly the whole anatomy. We can use the staplers in older children, but the neonates and infants we do not use. But you know, there is right now the 5mm staplers, which cannot be used. And again, one other recommendation is do not hesitate to convert the thoracotomy. In any case, in case of any suspicion, you can go directly to thoracotomy. It could be life-saving. And blood for transfusion and thoracotomy operative set must be ready all the time. So since the first description by Steve Rothenberg in 2003, thoracoscopic lobectomy for congenital lung malformations has been shown to provide decreased hospital stay and decreased time of tube thoracostomy when compared to the open resections, without increased risk of perioperative morbidity. And additionally, most children exhibit normal long-term pulmonary function following resections. And the surgical technique continues to evolve, with outcomes improving as surgeons gain more experience. And recent advances in minimal invasive instrumentation, including the development of these 5mm endoscopic staplers and just right, the 3mm ligature device. And these promises to address some of the remaining challenges of thoracoscopic surgery in small infants and also neonates. So to conclude, thoracoscopic resections for congenital lung malformations are safe operations in experienced hands and also in centers. So thank you for listening and thank you for having me here.
Thank you very much, Dr. Aider, for your nice illustration and presentation. And now the whole distinguished speakers will be interacted with moderators. Professor Dr. Akram Batarni and Dr. Mohammed Debeki will ask questions and you have to answer. And afterwards will be direct interaction by raising hands. Dr. Akram and Dr. Debeki, please take your turn.
Okay, thank you for all speakers for these illustrative lectures. We have a question: how can you differentiate between a primary congenital lobar overinflation with secondary mediastinal compression and consolidation pneumonia to other side lung from primary pneumonia of one lobe with secondary overinflation?
Yes, this is a very good question because in many situations we have misinterpretation of congenital lobar overinflation. Actually, in case of congenital lobar overinflation, usually we can say two issues. First, you will get overinflation in one side, and this will have both mass effect on the contralateral side with shift of mediastinum to the other side, and also on the same side we get also a mass effect. We can get compression reduction or some sort of consolidation collapse on the same side. And if this huge or very large overinflation, we can get this mass effect on the other side causing compression and a little bit consolidation collapse. But this is a little bit less than on the ipsilateral side. You will never get a consolidation as a consolidation because during your evaluation by high resolution CT, you can differentiate between actual consolidation and between the mass effect due to collapse of the lungs. So we have differences between consolidation and between collapse. On a clinical base, we have definitely differences between auscultation-wise when you have a pneumonia with consolidation like that. And usually if you have a consolidation, you will never have a collapse. Yes, if you have a consolidation collapse, so you have an endobronchial obstruction in this situation on the affected side that will lead to overinflation on the other side. So you will never get a consolidation that will be associated with compensatory overinflation to the other side that will lead to mass effect. So if you have something like that, so you have an endobronchial obstruction, which lead to consolidation collapse of the right side, for example, that will lead to compensatory overinflation on the other side. And here you have an endobronchial obstruction, and this is not a classic pneumonia, as you can say. So the interpretation of the condition all in all, usually you have there is this question, definitely you will never get a pneumonia with consolidation that you will be misinterpreted. But if you have an endobronchial obstruction with consolidation collapse, it may be associated with overinflation on the affected side. And the frank interpretation, and in every patient with congenital lobar overinflation, we suggest that you are doing bronchoscopy before any surgical intervention for confirmation of the diagnosis and the exclusion for the other causes.
There is a question saying, is there an intraoperative test before bronchial closure of the specific lung lobe?
Take your left hand with a grasper for the bronchus you want to occlude, and then you ask anesthesiologist to inflate. And if, for example, the middle lobe still inflates, you know exactly that you're doing the right thing.
Okay, that's perfect. Another question again to Professor Algertil. Did you think still a place for VATS when with open instruments during the learning curve?
Yeah, I saw that question. Clever, yeah. Of course. Just do what you feel comfortable doing. Okay, so to have a little incision and you put a 5mm instrument in there openly, to just make everything safer. This is absolutely in the benefit of the child, and you do not violate any rules. There are no rules. The rule is safety, safety, safety. So good.
Dr. Nader?
أيوة يا فندم سامع حضرتك.
How do you deal with symptomatic neonatal cases?
Yes, definitely if you have symptomatic neonatal patients, as we can say that we are in need in this situation to wait and see that if these symptoms are due to you have a general evaluation. Either you have a lesion, which is definitely have a mass effect that can affect or causing lung compromise with symptomatology. In this situation, you are in need for intervention even in the neonatal period. But we have many cases in the neonatal periods that they either have incidental finding or already prenatally diagnosed, because the era now of prenatal diagnosis is becomes a much help for us that we can estimate how many patients that can present early in the neonatal periods. Many of the neonates have asymptomatology. And in these patients, we are passing conservative for these patients till we make communications with the pediatric surgery for the intervention based on the situation with each patient and the other. But when you have a symptomatology in the neonates, which is related to the pathology, because we have many patients who have symptomatology to something else. But if you have symptoms that is related to this lesion, definitely you are in need for surgical intervention in the neonatal period.
There is another technical question coming from Professor Nabil Dessouky. How you manage cases of extensive lesion of the lung involving nearly the entire lung lobes on one side, necessitating total pneumonectomy, fill the chest cavity on that side, or you conserve one lobe although it still have remnants of the lesion?
That's of course a super rare case and a super difficult question. However, logically, every pathology must be resected. We heard this from Professor Nader Fassé about the complications, infections, and possible malignancy. Of course, you can do that stepwise. If my advice would be that lobe that is grossly affected must be resected, and then maybe don't do both lobes or all three lobes at a time, but wait. Because maybe at the end of the day, one lobe, you can do a segmentectomy. So I wouldn't be brutal. I wouldn't be a cowboy. I would stepwise approach that child, do the gross lesion first, see what recovers, see how it recovers, and maybe aim for a segmentectomy in the remaining.
Okay. Staged. Okay. There's another completion of the question also from Professor Nabil Dessouky, and how to manage bilateral lesions affecting certain lobe on each side of the chest, one stage versus two stages as well.
For a bilateral lesion, it's better to do each one side at a time, and try to convert the lung tissue as much as you can to do the level of resection down to the segmental level is better than total lobectomy and removing a normal lung tissue.
Okay. And is there a role for thoracoscopy for metastatic lung lesions? Aiden, do you think, do you have any experience with that? A role for thoracoscopy for metastatic lung lesions?
Yes, you can do some metastatic lesions with thoracoscopic surgery easily. You can even do a wedge resection if it's in the periphery of the lung. But if the metastasis is very containing large areas, you can go ahead make a lobectomy. But usually they're on the periphery, and you can make a wedge resection and you can remove them easily. You can do it.
I'm asking for if we have congenital pulmonary malformations, regardless the type of this malformation. in very few cases, and it is not common to get bisided affection. And in this situation, we have one side is usually larger one, which have a significant effect on the lung parenchyma, which may lead to definitely symptomatology. And the other lesion is usually less sizable one with less effect. So do you prefer to work only on one side, which is the larger one, and then to stay for the other one, to postpone or don't interfere till it becomes symptomatic?
Absolutely, I agree with you. Do the larger one first, that is causing the problems, and then wait for the other one and see how it recovers, how much parenchyma. It also depends on the age of the patient. We know that the lung grows until the age of about 3 or 4 years. So try to save as much lung parenchyma as that. I would like to, because I was asked, I would like to comment on the malignancies. I absolutely agree with Aydin. Absolutely. And I would like to add that a tumor is not a tumor, is not a tumor, is not a tumor. Even physically, when you have osteosarcoma or rhabdomyosarcoma, they feel like a rice corn, okay? They are tough, they're easy to identify, even during thoracoscopy, and they are manageable. If you have a lung lesion from a hepatoblastoma, it's extremely hard to feel and see those. So the question to thoracoscopic approach for malignancy is, every tumor is different, and this size and the location is mandatory. Let me be clear. All of us know these patients with, let's say, osteosarcomas. That is a systemic disease. They have 9 or 10 lesions today, and they will have 9 or 10 lesions in a year. So what you need to do is save as much parenchyma as possible. I would honestly, with my true love for thoracoscopy, osteosarcoma patients, bilateral metastatic disease, I would do one sternotomy and reuse that. The patient's life depends on that. And then you take 3 out of the upper lobe, 3 out of the middle lobe, 5 of the left lower lobe, and so on and so on. So don't be too euphoric about thoracoscopy in tumors. It's a different business.
Same comment regarding metastatic lung lesion. I've learned from my colleagues in National Cancer Institute that they depend mainly on tactile sensation that cannot be present during thoracoscopy. So they manage most of their cases by open surgery to feel the masses that they are going to remove.
The Dr. Holger and Aydin, please, if you have a case of 2 months age, do you prefer to do it at 2 months, or the lower limit is 6 months with minimal CPAM?
I can go ahead and answer. Well, yes. What we preferred previously, what we were waiting the 6 months. Right now, we started to operate them when we gain experience. We start to operate them earlier. And the earlier, the anatomy is more delicate and more, you can visualize the anatomy better. And they heal better, I think. So right now, I prefer to do it earlier. I mean, 3 months of age.
If the case at 6 months is smaller in size by follow-up than when it was at 1 month or 2 months, what you will do? Continue conservative, or you shift on? Still a lesion, but coming smaller and smaller.
Well, if it's coming smaller, you can go ahead and do nothing if it's asymptomatic. But we all know that more infection, the operation is more difficult. So it's an ongoing debate again in asymptomatic patients.
The protocol, Holger, please. If you have a protocol, until what age?
Again, I agree with Aydin. We usually wait, like I said in my talk, we wait until the age of 6 months.
Yes.
And before that, we only operate the severely symptomatic patients, just like Professor Fassi said.
But in some situations, I'm sorry for interruption.
No. I understand that Steve Rothenberg and the literature is going down to, yes, 6 months, 3 months, 2 months, immediately.
Actually, I disagree with Stephen at this point. Okay, I am with you. Okay.
No, he's the best in the world.
Yes.
So the best in the world can do things that I can't do. I just have to admit my technical skills and match them to the patient. But again, in Europe, and I think that's the same thing in Egypt, asymptomatic patients, there is no need to do it too early. We do understand the risk of silent infection, but I didn't say it clearly. Wait till 6 months and you're safe.
But one of the very important issue is that the correlation between the size of the lesion plus the symptomatology, and the most important issues is that we have in the newborn patients and the young infants that we have the process of pneumatization and the alveolarization is progressing. And so if you have a large lesion with compressed lung, so you definitely have some sort of pulmonary hypoplasia in this situation.
Yep.
And waiting for this large mass that cause pulmonary hypoplasia, I think that this is not good for the patient. So long as you are evaluating a large swelling with compressing and causing pulmonary hypoplasia for the affected side, even the patient, if he is not symptomatic enough, I think that in this situation, the earlier intervention is a little bit better. But if you have no hypoplasia and just without affection of the without causing hypoplasia for the adjacent or the opposite lung, I think that you can wait. So I think that we have a collaborative team between the pediatric pulmonologist and between the pediatric surgeon or the surgeon in order to take the decision, which may differ between patient and another patient. And you cannot put a unique rule for every patient because every patient is its own.
Would you consider lung transplantation in advanced cases? Probably we should listen to all of our speakers. When would you think of lung transplantation in advanced cases? And is it available in your centers? I don't know, because we are starting that very recent in Egypt and we didn't do any cases yet. The team is still setting up. So I wonder if there is any in Austria or in Turkey.
Well, I can say that I have no experience about lung transplantation, but as far as Zafer is here, in EPSA University, they have some, I think, cases, and if Zafer can be able to answer it, we have some experience there.
So do you refer any cases, any advanced cases that you think that it's that will need to do lung transplantation because after resection the residual is very low? Have you seen something like that?
No, we had no experience about that.
Okay, very good. And Holger?
I only know about one child with complete tracheal agenesis, a completely different topic from tonight, that required lung transplantation very early in life. Otherwise, that's a completely different profession. No experience.
Because even in the congenital diaphragmatic hernia with severe hypoplastic lung, it is failed afterwards.
Thank you very much. Very interesting, and it's nice to see Holger and Aydin and everybody in there. You want a comment about the transplant? We don't have any experience of the transplant, and we didn't have any case to actually transfer it for transplant. And the transplant is done at the Brompton, where it's related to us, but we haven't had any cases to refer them. I would like to thank everybody for the actual excellent lecture. Can I just ask Dr. Nader? He mentioned that even after surgery, you can have malignancy. Is there any reported cases, or is that incomplete resection of the actual lesion? The other thing is, I would like to ask Holger And usually it's a fantastic presentation that he did. How you mentioned that sometimes you wait until the age of 12 months and your patient selection is very important. So in which cases you wait until 12 months instead of 6 months? And the other thing about the complications of the laparoscopic or thoracoscopic lobectomy or segmentectomy, have any either Holger or Aiden have cases of chylothorax following that? And then I'll stop here now.
Yes, I can answer the question directed to me.
Yes.
Professor Dr. Monzer, I presented two issues that we have. There is a reported cases of, I have no any experience except in only a case of pleuropulmonary blastoma, in which an infant from Pakistan who visited Egypt, and the cardiothoracic surgeon did an operative interference based on a CT report that he have a CPAM actually, and the CT report told that he had a CPAM type 1. And this patient who was 3 months old, he did this operation, and then the surgeon, after doing the operation, he referred the case to me because they have a recurrence. And so when I examined the patient, definitely from the first CT, he had a partially cystic, partially solid, or type 2 pleuropulmonary blastoma. It is not a CPAM. This is the only one case that I faced it in practice, in my practice. Actually, because the cardiothoracic surgeon depends only on the report of the high resolution CT without referring the case to a specialized personnel for combined diagnosis and the confirmation of the diagnosis. But as regards the literature referred as reported cases of carcinoma, which may be related to the CPAM or any bronchopulmonary malformations, actually I have no experience because most of these cases occur later in life, in old age, which is not yet in the pediatric age, usually at 40 years of age or even 45 years of age, in which the patient definitely lost his communication with the pediatrician. And actually, my series is starting just only from 20 years when I am collecting all the cases that I have from the cases of CPAM. So I have only experience for 20 years, which is not small, but not too large, and actually not following the patients after that. And we have no communication with the older doctors. My part of the answer. Thanks, Professor Dr. Monzer, for this question, and I thank you.
Concerning your questions, when do I wait till 12 months? I think one of the nice things tonight is the discussion with this fantastic pediatric attitudes by Professor Nader Fassé. I mean, it's a teamwork. You treat these patients in a conference as a team, together with the parents. And we know that there are so many hybrid lesions that don't have a clear yes or no, that yes, we wait until everybody is happy that surgery must be done in the asymptomatic cases. Okay, obviously the symptomatics must be done again in the same group as a team approach. But Munter, if there is a family that at the age of 6 months says, well, listen, he just started to crawl and he will walk tomorrow, can we come back 6 months later? And it's a small lesion and nobody cares about it, really, and then we wait because malignancy has been ruled out. So I don't mind waiting. I don't mind following Professor Nasser's path, which is individual decisions taking the family into consideration.
What do you do for chylothorax, delayed chylothorax for that?
Aiden?
Well, I have no experience about even doing the thoracoscopic lobectomies, but we have observed one case after resecting, during the resection of esophageal duplication, a chylothorax period, and with unsaturated fatty acid intestines and nothing per mouth. It went well, and it goes directly well, and it disappears. But other than, we had no such experience about that.
Agree. It's a rare complication for lobectomy because you must somehow get into the mediastinum or close to the mediastinum.
Can I just congratulate Professor Fasih Nader? It's fantastic to have a pulmonologist who is in support of surgery. We had we had some antenatal diagnosed CPAMs or pulmonary malformations, which actually the neonatologist would not refer it to us. And some of the pulmonologists even are trying not a conservative management rather than referring it to us. Do you have any protocol, or how is it in Cairo regarding neonatologists and the pediatric pulmonologists?
Alexandria, actually.
Alexandria.
Yes.
In Egypt.
Yes. In Egypt in general, and in my university in particular, in which we have a very good communication with the pediatric surgical team. And so we have a very good link with the pediatric surgery and the pediatric pulmonology. But actually in the neonates, they are a little bit, they are focusing about mainly about the main problems of the neonates, but they are not yet fully aware by full details of the bronchopulmonary malformations in general. And many of them are lacking the details of these lesions and how to deal and to take the proper decision. And once the newborn or the neonates is asymptomatic, or in the contrast, he may have other problems that lead to respiratory distress other than the CPAM or the congenital pulmonary airway malformation, because many neonates have neonatal problems with respiratory distress rather than the congenital bronchopulmonary malformations. And in this situation, he may get fast track for doing surgical intervention, and we are not in need to do that in some situation. And I am frankly saying that we may have some interlink or not yet well communication with the neonatologist and actually with the pediatric pulmonologist. I think that we are in need in my university in a good participation with each other in order to reach the optimal for solving this problem. I think that more awareness in the upcoming future, I think that will help much. But definitely we have a very good communication with the pediatric.
Thank you very much. Thank you.
Thanks a lot.
Thank you.
Holger, please, go ahead.
When it comes to congratulations, I would like to echo and join and congratulate Professor Ahmed Fares and his group. If I understood your Cairo case as well, you did an upper lobe, you did another upper lobe, you did another upper lobe. You had a case with an incomplete fissure. So congrats, absolutely congratulations to your skills, to your setup, to your preparations, because you did the most difficult. I think the next series should be 20 lower lobes and an easy day.
Thank you. Regarding chylothorax, the question regarding chylothorax, we have experience with chylothorax following thoracoscopic repair of esophageal atresia, because the thoracic duct is passing near the azygous vein. Sometimes we have one case that it was injured, and we managed to control it conservatively, and the chyle leakage stopped with conservative treatment. I have one question regarding the use of the new contrast medium ICG in detecting in chylothorax. Have anyone experience with this technique? ICG, endothelin green for management of chylothorax. This is a new.
Or during lobectomy even?
Or during lobectomy, I found this question.
Holger, please.
We do ICG for varicocele and gallbladders, but I think it's a good idea. Could be tested.
A couple of comments coming from Dr. Gürsu Kian. She shared the case report about the bronchoalveolar carcinoma of the lung and congenital cystic adenoma malformation. So anyone who is interested can have a look on this. And she also gave a comment for the friends asking about surgical treatment options for extensive bilateral diseases. You have the conservative option, and there are algorithms for conservative follow-up. You can also check for DICER1 mutation if you have the opportunity, just a suggestion. And I think by that, we have done most of this. And if there is a question also coming from, what about cases of pleuromediastinal lesions that presented with neonatal respiratory distress that converted to be asymptomatic with follow-up, conserve versus surgical intervention? What do you think?
Aiden?
What's actually meant by pleuromediastinal lesions? He is not clarifying which type of pathology, pleuromediastinal, which one, which type of pathology he is asking about. The question is not well clear for me.
Not clear.
Yeah.
Okay.
There another repeated question, actually, when Sharif Shahata was talking about CDH, about separation of hepatopulmonary fusion during CDH. So anyone, I think it's rare, but anyone from the surgeons have seen a case or more than one case? Holger, Aiden, Ahmed Farid? No?
By personal communications, there is one with Darius, Dark, and he used the harmonic for separation. Sometimes it's very difficult, and he is against ligature also like Holger, but he have only one case with Darius Patofsky.
I have one comment. I have seen one case of right side diaphragmatic hernia with a large vessel traversing from the lung to the liver. I did this case by open thoracotomy, not thoracoscopy. I closed the defect around. I tried to preserve this artery and not to divide it as I thought it could carry hepatic venous drainage from the liver direct to the lung.
The problem, Faris, how you can close the defect without dividing the fusion. It's technically difficult or impossible. So you have to compromise.
I didn't close it completely. I closed it.
Yeah.
And Dr. Usama Nagar also mentioned that he has 2 cases of pleuropulmonary fusion.
There's a question about, is there a specific age below which you can use ligature safely to control vessels and also to control lung parenchyma in cases of non-anatomic resection or lung biopsies?
This is for Holger, the ligature. You are fun on.
This is too ideal for the complications. Aiden, first?
Well, of course, most of you have seen how Steve Rothenberg was doing these operations, and he's not always using a ligature or clip to cut the arteries. He's using ligature, especially in neonates, and he's doing these operations. I think he has been done these operations more than anyone in the world, and he reported no complications regarding this. But I've seen some complications using ligature. I mean, ligature, the vessel sealing devices can get sometimes sticky, and when you try to remove it, you can tear the artery, and it can make a huge complication, huge bleeding. So I don't feel myself safe when I'm using the ligature, so I try to ligate or clip it before using the ligature. But I've seen Steve Rothenberg doing it safe and nothing happens, but I'm not sure.
This is about
Holger,
the fourth time
clarify, because you are against. Okay.
I agree every time with you. Okay. Let me just add, the Rothenberg technique is very special. You have to watch him very closely what he is doing. He is doing 2 seals at least.
Yeah.
Like clips and cuts in the middle. And when you hear him teach, he says those instruments like ligature that seal and cut in once are dangerous. So seal, tissue in between, and cut here is safe. And that you can do at any age downwards. Once the vessels get up to 5 millimeters, I would be very careful. But again, the modern seal, not one seal and cut at the same time. Seal, tissue in between, cut. Agree?
Yeah, agree.
And if you don't have enough lens?
Well, don't make one mistake worse by another mistake.
Okay. Create enough length.
Yeah.
Dr. Nader, should all extralobar sequestrations be resected? And should all congenital lobar emphysema be operated even if there are no symptoms?
Yes, so we have 2 questions. First question is, intralobar sequestrations or extralobar sequestrations, extralobar sequestrations are in need. As you know that in many situations, the extralobar sequestrations are usually associated with other congenital malformations. So first, you should interpret the patient well for the possibilities of congenital diaphragmatic herniation or congenital renal dysgenesis or cardiac problems. Actually, in many situations, we are not in need for interventional or surgical intervention. In most of the situations, but in some of patients, I think that a lot of pediatricians, that when they find the report, which incidental finding that he had extralobar sequestration or something like that, he may interfere with. I think that not all patients with extralobar sequestrations are in need for surgical intervention, and you can wait and see for the possible time if we have a complications or not, or recurrent infections or not, or related problem or something like that. This is the first question. The second question is so much difficult to be answered. And I think that for many pediatric pulmonologists worldwide, this is a very big problem to take a decision when to surgically interfere with congenital lobar overinflation. Because we have a lot of many patients of such type of patients that if you follow them by age, you will get partial improvement in the clinical situation. So if you take the decision so early and you may, for incidental finding, the patient refuse to do surgical intervention, and then to follow the patients after many months or many years, you will find another situation. So you are in need for a long experience in order to check when to take a decision for congenital lobar overinflation. And actually, again, bronchoscopy is very essential in such type of patients for avoidance of doing wrong diagnosis for evaluation of the congenital lobar inflation. Definitely, when you have a frank symptomatology with severe respiratory distress, this is a sharp decision for taking surgical intervention, especially early in the neonatal periods or even in the very few months of life. But sometimes you may get an older child who came to you with X-ray or high-resolution CT with congenital lobar overinflation without any past history before for having a big problem or chronic or recurrent chest problems. Just recurrent cough and wheeze from time to time, exactly similar for asthma patients. So if you have a large congenital lobar overinflation with definite contralateral and ipsilateral mass effect, this is frank decision for doing surgical intervention. Otherwise, if you have no contralateral or ipsilateral mass effect, I think that you can postpone for this decision based on the clinical course and follow-up of that patient.
I got just that question, if you don't mind, Dr. Nader, about that. What about the effect on the future athletic activity for those children if they are still asymptomatic? Would that hinder their athletic activity? I mean, would it get worse if they start doing like any form of exercise and severe exertion?
Yes, definitely after doing bronchoscopy in very different stages for such patients, definitely we have bronchomalacia or segmental bronchomalacia for such type of patients. And this segmental bronchomalacia may improve by time or improve by age, and they will get improvement of the clinical manifestation of the segment or lobar affection if you can justify this patient later on. And definitely we have no research work done. What we didn't know or do a research for doing pulmonary function testing for such a group of patients who are seeking or didn't operated upon in the early neonatal periods or even in young infancy, and then and the diagnosed late even in above the age of 6 years, because all of us know that we cannot do pulmonary function testing except beyond the age of 6 for the cooperability of the patients. And so actually I can't answer this question because I have no any research to justify or document if this patient can be affected or they have an exercise limitation or have some sort of obstructive lung function that can interpret or interfere with their full activities or not. So I can't answer, but I am discussing in general about the symptomatology, the recurrence of wheeze cough or recurrent chest problems, but not discussing the point of exercise. I think this is a point which are in need for research, which may be a point of discussion or point of research for me in the upcoming few months.
Waiting for that.
Still one standing question, the use of ligature for controlling the lung parenchyma, alveoli in segmentectomy. Do you prefer using it or using ligatures or clips for the surgeons? This question is for the surgeons.
Dr. Holger?
Ligature is safe for parenchyma, as long as you use 2 seals.
Yeah, you can
even for segmentectomy?
Yeah.
Yeah. Or stapler is better?
If the child is, stapler is better if the child is old enough to get it in. Yeah.
Dr. Usama Nagar is raising hand.
Thank you very much about these presentations and this very interesting subject. First of all, I would like I have a comment about conversion. Actually, conversion in thoracoscopy or even in laparoscopy will not make the operation more easy. So if you are obliged to convert from thoracoscopy to a thoracotomy, you have to ask for help because patients can die from bleedings, especially in these delicate lesions and delicate patients. So the important thing is that we should not have a sense of security if we convert from thoracoscopy to thoracotomy, because still the operation may be difficult and it will not be easy by conversion. This is one thing. The other thing is about the problem or pathology of hepatopulmonary effusions. I have 2 cases. One case we suspected before the operations, and we did what we have to do, and in these cases we did CT scan angiography, because the important things about to judge about the possibility of separations of the lung and the liver is to understand the vascular anatomy, both the inflow and outflow of both parts of these fusions. So by doing this CT angiography with 3D reconstructions before the operations, we were able to determine that both circulations are separate, and we use the ligatures to separate the lung from the liver, and we close the defects, but sometimes you will have the hepatopulmonary fusions at the surprise. That's what happened in the second case. And in these situations, we could not do separations. And what we did is that we fixed the edges of the diaphragmatic defects to the part of the hepatopulmonary fusions. And this helped us to prevent any herniations, which, because in this situation, this is the only problem that we have. So we prevented herniations of abdominal contents into the chest by approximating the edges of the diaphragm to the edges of the hepatopulmonary fusion. Thank you very much for the lectures and presentations, and thank you.
Dr. Nabil is commenting in the chat area, has a problem with his mic. So his comment is to give medium chain triglycerides in case of chylothorax. This is a good medical non-operative solution to the problem.
Yeah.
I think now it's okay. No more. We have to thank all our speakers, Holger, of course, and Aiden. And it was a pleasure to have you all with us this time, Dr. Ahmed Faris and Dr. Nader Fasih. We will have one panel in the Alexandrina Biblioteca with you, as we all know.
All of you are invited.
The same subject or another one, because we have common defended 2 times theses, one on congenital lobar emphysema and the other was hyperreactive airway with reflux in children. We have a pediatrician with surgical mind, so he is very helpful to Dr. Samah, and we all nice to have you, and all of you have a good time today and stay safe, and thank you for participation in the EPSA program. Thank you for see you in a nice way.
Meet you in person soon again.
Hopefully,
yes.
Meeting
possibly,
is
many thanks.
Possibly,
many thanks.
everything is possible. Okay.
Bye-bye.
It's outstanding talks and webinar, but real meeting is something different. So thank you all, but the next time needs to be a real meeting.
Inshallah.
Thank you. Bye-bye.
Thank you so much.
Bye-bye. See you.
Yeah, inshallah.
Bye-bye.
Shukran.
Thank you all.
Thank you all.
Thank you.
Thank you.